Thanks very much, Braden. Catherine, actually, if you want to just come up to the table, and we'll just have a few minutes of questions just with you and Braden before we take a break. If there's any burning questions, there are some, or even questions of each other, just for a few minutes before we take a break with the panel. So I don't know if anybody might want to balance up to the mic or have any particular kind of comments. I might have just one quickly. Catherine, how, because Braden I know is trying with the strategic clinical networks how to change and address variation, measure variation in practice and implement more consistent practice across within Alberta. Are there similar groups in Scotland like the strategic clinical networks? I know there was a national clinical strategy developed, which was with the specialty groups, but are there things from your assessment that might be able to drive this is the appropriate care in this particular kind of, and have some teeth associated with driving it through performance in the Scottish health system with clinicians?
So, and I like the strategic clinical networks very much, actually, and having spent time with Braden and some of the others on whatever day that was, it's something that I will take back. And as I said in my opening remarks, that's why it's always great to come and speak to find out how people are having solutions. We would have big national audits, and those are, and then we often in government go in and give some help when there are poorly performing parts of shown up by audits, but we don't have something as strategic, I suppose, as with the specialty groups. So I think it's a very good way to combine what we would have. Our maps of variation would also then have the audit. We could bring all sorts of pieces of data into something that Braden's already doing.
And I'll put Braden on the spot. How do you think Alberta physicians would respond to a proposal to be salaried employees of Alberta Health Services?
You could do a show of hands.
John, I would say not well. I would say the reason that the specialist alternate relationship plans have worked is because it's actually allowed physicians to practice in different ways, to work in multidisciplinary clinics, to not necessarily need to see the whites of a patient's eyes, to sort of supervise the roster of patients as we talked about. But even when specialist physicians changed payment models, it took me years to actually sort of realize how I could practice differently. And I start clinic now with an hour of phone calls before I move into the actual formal clinic. I email with patients. Sorry, I'm not sure if that's okay with the college. And I have different ways of interacting with them. I actually, Ontario, New Zealand, they moved physicians onto salary or away from fee-for-service models by paying them more, and I think they regretted that afterwards. One wonders, emerging or recently graduating physicians, they have different, they're more interested in a work-life balance, and I think they're interested in practicing in different ways. And one wonders if the government wants to encourage different funding models, whether just moving forward, in most areas we offer billing numbers with salaries, for instance, or with sessional payments, or with blended capitation, something that the AMA has to, because it's harder to take things away. So it's going to be difficult, I think, in some ways to move people off of fee-for-service. Fee-for-service is still an important model for certain things. Like, I don't love coming in the middle of the night. And I think physicians who work at night, you may need to incentivize them that way. We may need to incentivize care in certain areas, remote areas, through blended models that have fee-for-service attached to them as well, although sometimes salary-based models work better in those remote type of settings. So I'm not sure if that's what the government wanted to hear, but...
No, I think that it's good. And just one last question, Catherine, just on the performance indicator reports that you have just been released this week, and now you're planning to do more. How far do those performance reports on variation in care go down? Do they go down to the clinician level or the unit level or the region level? And are they looked at closely by the public or by the media? Do they receive a lot of feedback from people in terms of observation about the performance of their system?
Since yesterday, when they were first published, I don't know, but the idea is that they're public. So they go down to health board area, but then you can interact with them and bring it down to a more local council area. So that's a smaller point in the population. Our idea would be to see how they are used. So what we've said is we'll just put these up and let's see. Are clinicians going to use them? How would they use them? Are they useful like that, or would some further granularity help? So our commitment and the way we've designed them is we could go drill right down but is that going to be useful? So they're literally a work in progress, a live. We'll go out to clinicians, we'll go out to the public and see if they're useful in their current form or if they would be better to be adapted. We're going to add lots of different types of data. I suppose childhood obesity that's a very different, because that's not really one single, you can't modify that easily. Is that going to be something that's useful for public health? So I think the honest answer is, John, we don't know. It's a work in progress, literally published yesterday. I think the reaction from the newspapers yesterday was TripAdvisor for Scottish hospitals. You can imagine my delight. And so we're going to need to do it. There's a lot of caveat, and I only showed you the prototypes. There's a lot of explanation of them, and this is not to do with good and bad. It's not a league table. So, but we're going to have to work with them and work with people who are interpreting them.
Okay, well, thanks very much. We'll be emailing to everyone and also posting on the website the Realistic Medicines reports, which I think would be of keen interest, as well as some associated documents. And we'll be having a short break and then a panel with Dr. Scott McLeod from the college, chairing a very interesting kind of panel of Alberta reflections, including some patient perspectives and stuff of how we might adapt such concepts into Alberta. So thanks very much, and please join me in thanking Braden and Dr. Caldwell.